As they said, I'm John Wysocki. I'm from Connecticut GI. I work with Dr. Kappa, and I think I've met a bunch of people in this room already in the past, so thank you for coming out this morning. It's supposed to be 70 today, so hopefully we can get out here early. I'll be talking about precision medicine today. It's kind of the first time I've talked about this, but it's an interesting topic. It's a very hot topic, and it's a topic that I think there's a lot we realize we don't understand about this disease. So this is kind of an interesting statement I saw a number of years ago in fellowship, and I think it sets the tone for understanding this disease in general and kind of what's going on with our bodies. But Dr. Pravda is a rheumatologist, immunologist. It is perhaps among the greatest physiologic wonders of evolution that the most highly evolved immune system ever engendered can remain unperturbed while surrounding the highest concentration of bacteria on the planet, separated only by a tenuous sheet of tissue, approximately 1 cell thick. So, precision medicine. Probably a little bit of an oxymoron, a little bit of an ironic statement. When I first started, I did the first slide, I'm like, precision medicine. I'm like, this is kind of interesting. I'm like, medicine should be precise, shouldn't it? If you're getting a tumor cut out, you want that to be precise. If you're given a medication, you want it to be precise. But I think in IBD and what we're facing the challenges of nowadays and in the future is really understanding how precise this is. And as many of you in the audience have probably had these conversations with your IBDologist is, how effective is this therapy going to be? And when you hear that it's going to be, 50 to 60% effective, I think it throws a lot of people off, especially my patients, because you expect 2022, these medicines should work. They should work all the time. And I think as we get into with a little bit more of the detail, understanding why we're only but so good as of now and kind of the factors that play into what lies ahead as we, as an IBD community, try to figure out how to best treat this disease, because we're kind of approaching this asymptote that we see in all these clinical trials and maybe peaking above it if you tweak it in a variety of ways or experimentally. But there still is this great unknown in this disease, and I think precision medicine is giving us an idea as to what these targets may look like and what the future may look like. So truly precision medicine is, as by definition, it's directed at characteristics of the individual patient. As Dr. Kappa alluded to, understanding patient by patient, one patient with ileocolonic Crohn's disease is not the same as the next patient with ileocolonic Crohn's disease, one patient at a time. But trying to direct that therapy comes from a series of conversations, labs, imaging, endoscopy, other medical problems, where you really have to figure out the right therapy for the right patient at the right time. Much easier said than done, as you can imagine. In diseases like cancer and diabetes and high blood pressure, precision medicine makes a lot of sense. They have these markers in cancer. Are you BRCA1, BRCA2? Or for blood pressure, maybe something else, or diabetes, something else. But you have very tangible targets that are achievable with the medications that are available and clinical trials that support efficacy of a lot of these medications. IBD is a little different than that. It's still probably in its infancy is the best way of describing it, but I think that gives me both and all of us hope as to what lies ahead in the future and the things that we're researching and looking into, but also underlies just the complexity of this disease overall. So one modification I made to my slide is to continue on Dr. Kappa's theme. Think of precision medicine like the Matrix. It didn't win an Academy Award, but it leaves you guessing at the end what the heck just happened. There are a lot of variables, there's a lot of data flying around, and that underscores what goes on with precision medicine and the research going on today. Doing literature search in preparation for this, and you start reading about the bench science, which is kind of the nitty-gritty of of precision medicine, and understanding just the biophysics, the pathophysiology, the molecular, the DNA, all the things that go into it. It kind of looks like this screen. You're just wondering what the heck just happened. You need a PhD in order to understand a lot of this, but underlying it is there's a lot of research going on to understand at a very small level, a molecular level, a DNA, RNA level, a protein level, what is going on with this disease in your body and why it's different than just something like high blood pressure, diabetes that may be a little bit more straightforward with fewer variables. So a lot of variables in play. But I want to take a little bit of a step back first to better understand where precision medicine is or is going. We have to understand where we're coming from, because I think it builds a context for the story. IBD, natural history, there's obviously a component that's genetic. You're born a certain way, you have a certain genetic predisposition. There may be some environmental or nurturing things that come along the way in terms of Western diet, allergies, environment, infections, and so forth that either turn on or activate this disease at a certain age. Some people tend to be in the teenage years. For a lot of other people, we see these peaks in their 30s and 40s, and then again in the 50s and 60s. But what we're beginning to really understand is how much of a role the environment also plays into this. They've done studies where they look at people who have come and immigrated into the United States, and they look at the second generation of people after they've come to the US or another industrialized nation and been exposed to the Western diet, so to speak, and they actually see a statistically significant difference in those people in the presentation and the onset of IBD versus comparable people who had never immigrated or came to a westernized nation. So underscoring a lot of this are things we may do to ourselves to activate this disease. But predisposed genetically, 200, 250 plus genes and counting. If you begin thinking about the complex combinatorials that go into understanding this disease, again, one person who has ileoclonic Crohn's disease may not be the same as the next person. And what underlies that is just how many different genes play a role in this. And we're just beginning to understand that. But the outcome of those genetic variations can be so different from person to person. And that influences which mechanisms are really driving this disease in a person. So this is an often referenced slide, we'll say. Jean-Frédéric Combel, he's out of Mount Sinai, does a lot of research on treat to target, which I'll get into, but I just want to use this as an example. This is Crohn's disease, understanding what a relapsing, remitting course of disease may look like. Somebody may develop initial symptoms where it may be very innocuous or subacute initially and kind of vague symptoms, and it may take a few years to even diagnose somebody with disease, or they may come in with a fulminant flare in which they're in the hospital for a few days needing IV steroids or sometimes even surgery. But these it can follow a number of different courses. Some people subtle, smoldering in a way, other people very acute. And this window of opportunity that's identified in the middle is really what we've come to understand as being the targeted area you want to try to get after disease, trying to predict and prevent and be proactive with therapy as opposed to reactive, which I'm going to talk about in a little bit. But the whole point of this is a lot of disease begins inflammatory nature, so controllable with medications. But the longer that disease goes on and the less effectively that it's treated and controlling inflammation may predispose you to complications down the road, such as stricturing disease requiring surgery or failure of other therapies down the line. So we have learned from a global perspective that proactive treatment for a lot of diseases in IBD, especially Crohn's disease, fistulizing, penetrating, stricturing, perianal are imperative to try to get this disease under control to hopefully prevent complications down the line. I'm not going to try to freak anybody out with this slide, as I call it, Immunology 101, and don't pay attention to all the stuff in the middle so much, but I just want to fundamentally explain what's going on with this. And kind of like the first slide, you have this sheet of cells 1 cell thick, preventing all that bacteria from accessing your system. But if you start at the top, and I often use a Star Wars analogy to describe Crohn's disease and ulcerative colitis, but you have all these bacteria, so you have the bad guys way up top, 100 trillion of them, and you have this mucosal layer, which is kind of like the force field over that layer of cells. You have a layer of cells, that's the mucosa of the smaller large intestine, which is between 1 and 5 millimeters, and that's basically the size of a nickel, so the thickness of a nickel. And then you have this very robust immune system. So just as sophisticated and amazing as the GI environment and the immune environment is of the GI tract to prevent these infections from wreaking havoc, you could also understand how any type of abnormalities within that system could also wreak havoc, and that's the thrust of why we do what we do. But you have this very complex immune system. We're not quite sure which people activate which mechanism, but there's some type of signaling process that goes out, and that's really where the problem begins. So some type of bacteria or some factor, virus, whatever it may be, all of a sudden amps up the immune system. Immune system sends out a number of variables to the system, cytokines and proteins and other messengers out to the global immune system saying, I need help down here. So your body very, very smartly starts sending things down there to help that battle. So those are the good guys in theory. Sends a lot of that down there. But the problem begins there is by sending all these factors to that area to fight this infection, which happens, or the bacteria or virus that happens, your body defeats that, but the message keeps going out to the immune system saying, I need more and more help. So more and more factors go in there, and that's where the inflammation comes from. That's where the trouble really begins. And so that signal keeps going out and out and out, and immune factors keep running to that area to try to help out. And all the medications we have to date are trying to prevent these signals of communication from going out or going out inappropriately. Steroids kind of shut off the power to the system, but it's not a great long-term solution. Other ones that we have, like Remicade, goes after TNF, and like Dr. Kappa talked about, Stelara goes after IL-12/23, but it's still a guessing game as to which mechanism is driving the disease. And at best, about 60% of the time, we're right at the end of 1 year, and it works and people feel well. But a lot of the time, we're not right. We're not sure. And that's what the thrust of precision medicine is all about, is really trying to predict all these different variables, who's going to respond to what therapy based upon genes and the microbiome and a number of other factors, but it's still in its infancy. So one of the most important things is identifying what type of patient we're dealing with. We risk stratify these patients. Depending on a number of factors for Crohn's and ulcerative colitis, that'll give us an idea how aggressive you may want to be with therapy, because we've seen some of these predictors like the Prospect or CD path that I'll talk about in a second. Those may help us understand which people are more prone to more aggressive disease, and you want to get more aggressive with your therapy accordingly. So for Crohn's disease, we know low-risk patients tend to be older patients with more limited involvement. It may not involve perianal disease, no fistula, no history of surgery, but the more moderate or higher risk patients tend to be younger, more penetrating phenotype like fistula, strictures, abscesses. Ulcerative colitis, again, young age plays a role, and the more disease you have, the more prone you are to higher risk. Numbers like CRP could be very elevated, hospitalization, albumin. So we use these to help us, in addition to what the patient is telling us, to identify what therapy may be the best for that situation. But by no means is this a clear-cut decision when a patient walks in. It's not algorithmic enough like it may be for other diseases like cancer, diabetes, and high blood pressure, but it is evolving. Some of the current targets we use for precision medicine, and what I say by precision is it's quantifiable. We can report to it, we can measure it. It may help us understand where we are right now and what a response may look like to therapy. What these factors are not necessarily good at, with the exception of the fecal calprotectin, is telling us what will happen, what could happen down the line. So you're often getting labs, something like CRP and ESR in some cases. A TPMT is something we use to help predict how somebody may react to azathioprine or 6-MP and how their body would metabolize it. Fecal calprotectin is kind of an interesting one because it tells us more about what's going to happen in the next 3 months, as well as now, but also in the next 3 months. So it can help us predict flares that may happen in the future. So we use this as a surrogate for colonoscopy in a lot of cases, which has pretty good sensitivity and specificity overall. TDM, or therapeutic drug monitoring, this is something we use to understand how patients are doing while on a biologic therapy, such as Remicade or Humira, Stelara, Entyvio, etc. So we use this in most cases to understand if you've developed antibodies. And antibodies are a great thing when it comes to COVID. You want to develop them, but when it comes to medications like Humira, Remicade, so forth, it's a bad thing, because what antibodies do is they essentially annihilate that drug you put in the body. They chew it up and it renders it useless. So developing antibodies to medications is not good in the case of IBD. So TDM is a way of us measuring how much drug is circulating in the system and also seeing if your body has developed antibodies that would render it useless and then force you to go on to a new therapy, usually outside of that class. So that is one of the more helpful tools we have nowadays as part of this precision medicine. But again, it doesn't help us predict what's going to happen in the future. It lets us know about where we are right now. So future targets in precision medicine, and this is kind of the most very interesting area within IBD as we get more and more molecular with what's going on, because before we were just very reactionary in what happened. How inflamed are you? What does the CT show? How bad does the colon look? But a lot of the research that's out there right now, and research that actually CCF is helping to conduct, is looking more molecular, looking at the genome and the DNA, looking at the RNA, looking at the proteins and the fats. These are going to help play a significant role in the future in allowing us to understand what's going on mechanistically at a very basic level, because that's going to influence what kind of medications may be most appropriate for people down the line, whether it's an anti-TNF agent or an IL-12/23 or small molecules that have been talked about already. There's some prognostic tools that are out there. Prospect was one of them, which now became CDPath most recently. And this just looks, again, into the future about how people would behave given their disease. Age, gender, and a number of other factors may help identify low, medium, high-risk patients. And it's trying to quantify it, looking at some of the genetic markers, blood test markers, and so forth. But still, it's not a bulletproof tool, so to speak. It's just helpful as part of the grand picture of what's going on. Some of the interesting stuff coming out of Connor Lamb, doing a lot with precision medicine. Currently we have some stuff out there for blood work that we talked about with looking at drug levels in TPMT and fecal calprotectin. There's some urine studies, but really looking down the line, it's understanding metabolically what's going on, protein-wise what's going on at a very molecular level. And so that's really the future of precision medicine, so we can identify which medications are going to match up with which defects, which problems are going to be most critical to getting this disease under control, because the combinatorials, again, are overwhelming and kind of look like the Matrix. So really, to echo what Dr. Kappa said, a lot of medications in the past were reactive with things like Remicade and various mesalamine moieties, and that took us up to around 2000s, and then all of a sudden infliximab came on the scene, followed by adalimumab or Humira, and we begin to see this acceleration recently as more and more agents become available, which is great because we have more in our armamentarium than we had before. But still, the asymptote that we're approaching of treatment efficacy is still 60% at best. So there's still a lot that we do not know that people think is wrapped up in a molecular level and in a DNA level. A lot of agents being approved in the next couple of years, which is wonderful, more in the armamentarium. But again, I think we're still see that there's more that needs to be added to this picture. This is just echoing all the different medications in development and about to get approved. So historically, our reactive type of treatment concepts still will treat disease. People often require surgery. They often have relapse. They often need to go into other medications. As we've gotten more proactive in understanding that window of opportunity and these concepts called treat to target, we now understand how we can be more aggressive with therapy. We can define what outcomes may look like in terms of CRP, endoscopy, and so forth, to define what success may look like, whether it's deep remission, which is clinical and endoscopic remission, or the deepest remission, in which those two plus histology remission has been achieved. Again, just that window of opportunity, the more proactive, the better, but we're still lacking in understanding in the long term, predicting outcome and predicting medications that best match up with patients. So Jean-Frédéric Combel out of Mount Sinai again did an interesting study called the CALM study a short time ago, looking at treat to target by being very aggressive with therapy, defining what goals are in terms of fecal calprotectin, CRP, and symptoms. And if you're not achieving those, then changing therapy to be more proactive. And they found that there were some positive outcomes by doing so. It's still not I think there's been other studies subsequent to that have shown mixed reviews, but I think it's a concept overall that people are gravitating towards because, again, when we look at rheumatologic data, we look at oncologic data, we see the benefit of people having more quantifiable and more targeted approach to treating disease. Underlying this is just defining the treat to target concept. You need to have goals, and this is a consortium that got together to define what those goals may look like for Crohn's and ulcerative colitis, because people need to have a common goal in order to do clinical trials, in order to understand all these variables and what outcomes may look like. Again, just reiterating the CALM trial that was done. Stardust was another one. There are a host of these that are out there as well, looking at similar concepts, but these are just a few examples that people might have heard about in their own offices. And just to recap, again, the overall goal of precision medicine, trying to find the right patient, the right therapy at the right time. This is not as scientific as we would like it to be currently, because there's still so many variables out there that we do not understand, but there's a host of research, a host of clinical trials that's really helping us to understand these elements better. The microbiome, the microvirome, the mycoproteome, DNA, RNA, proteins, etc. So I'd encourage people at the local level. There are trials available through Crohn's and Colitis. There are trials available at institutions you may be going to around the Northeast. But underlying all of this is it's a very, very complex set of variables. There are a lot of permutations, and we still have a paucity of medications that are available to us, given all the different variables that are in play. So I encourage you to get involved. I think there's a lot on the horizon that's going to be incredible with this disease. I'm excited about the next 5, 10, and even 20 years, because I think the genome, the microbiome, and these molecular targets are really going to change the face of disease, where we can look back 20 years from now and kind of chuckle about 60% effectiveness with these medications and talk about 90, 95% effectiveness. So we need your help, most importantly. So thank you for the time. Appreciate it.